Khanna, we have a timer straight across. May I request you to kindly pay attention? Over to Dr. Roopali Khanna.
Good morning, everyone. So I have given a topic of approach to patient with narrow complex tachycardia, and how much justice I will give in front of extreme panelist or chairperson, I'm not very sure, but I will try my best to sum up in 10 minutes. So if we see by definition, a narrow QRS tachycardia is, as already discussed by our earlier speaker, it is the tachycardia with a QRS duration of less than 120 milliseconds. If we see the prevalence, it's seen about in 2.25 per 1,000 population, and it is common in all age groups as compared to wide complex tachycardia. And a heart structure, it's not to be involved. It can be a normal structural heart, can also have narrow QRS tachycardia. And if you see the overall prevalence, women are 2 times have a higher risk for developing a supraventricular tachycardia. So all arrhythmias which are originating above the His bundle are known as narrow QRS. Either it could be a AV nodal reentrant tachycardia, either it could be accessory pathway or AV reentrant tachycardia, or it could be a atrial tachycardia. So is supraventricular tachycardia is equivalent to narrow QRS tachycardia? So by definition, anything coming before ventricle is narrow QRS. But as already mentioned by our earlier speaker, all supraventricular are not narrow QRS, they can be wide QRS also in terms of rate-related aberrancy, pre-existing bundle branch block, or antidromic tachycardia. So we can say all supraventricular, not narrow, but all narrow are supraventricular tachycardias. So how to approach these patients? If we see, we have to see the first with the clinical history. So these patients usually have a little subtle histories of palpitation, lightheadedness, and syncope is rare. But if the salient features in history, if you want to rule out, is the age. If it's a young patient, a young age would more of a re-entry tachycardia or AVNRT or AVRT, and elderly will more having atrial fibrillation or flutter. If we see the onset-wise, if it's a sudden onset, we assume it's a re-entrant tachycardia, and if it's irregular, we assume it's flutter or fibrillation. And if we give patient classical history of prominent neck veins, or if they are terminated by Valsalva, then we should suspect it's a AV nodal dependent tachycardia. So if we see the mechanism in these cases, all arrhythmias, either it can be a re-entry, automaticity, or trigger activity. I will not go into details in this part. And the mechanism, it can be nodal dependent or nodal independent. Why it becomes important in making the differential by giving AV blocking drugs. How can these part of etiology can be differentiated? So how to evaluate? So patient comes to you with a tachycardia. The first and foremost we have to look is the regularity of the rhythm. Is it irregular or irregular? If it is an irregular rhythm, there are only 2 or 3 DDs which we have to look at it. It can be the AFib, it can be atrial flutter, or it can be a multifocal atrial tachycardia. What is an atrial flutter? If we see the atrial flutter, it is basically a heart atrial rate of 250 to 350. We will not get an isoelectric line between 2 P waves, and it will give a sawtooth appearance in these cases. Depending on the variable AV conduction, it can be regular or irregular. So if it is a variable AV conduction, it will be more irregular type of tachycardia as compared to if it is a 1:1 or 2:1 conduction. Multifocal, if it is irregularity, would be that means it's originating from the different foci from the atria, and if we see the different P valve morphology, more than 3 types of P wave, it is a multifocal atrial tachycardia, and it is mostly an irregular tachycardia. So we see the ECG, we found irregularity, these are the 3 DDs which we have to consider. If it is regular, then we have to look for the P wave. Are we able to clearly see the P waves, or we are not able to clearly see the P waves? If we are able to clearly see the P waves, are the P waves more than QRS? So we see that if the P waves are more than QRS, that is foci is the atria, either it's an atrial tachycardia or it is a atrial flutter which we see. Or if we are not able to see the P waves clearly, but since there we suspect that there is some P wave in the morphology in the QRS, either it is in the emerge in the QRS or in the STT segment, we look at the RP interval or the PR interval. What is that? We see that QRS is it followed by a P wave, and this P wave, the duration of RP interval is short. Then the DD comes our AV nodal reentrant tachycardia, AV reentrant tachycardia. And if we see that the RP interval is long, that is RP is more than PR, then the DDs comes our atrial tachycardia or atypical AVNRT and with a fast slow pathway, or sometimes a PGRT can develop this type of RP interval tachycardias. So we see the P wave, we look at the RP interval. There is obvious RP, P wave is not obvious, there is short RP, you can have a QRS inside the P wave, then it is a AVNRT. If the P wave is emerged in the ST segment, it is AVRT. And if P wave is well after ST segment, it is a atrial tachycardia or sometimes atypical AVNRT or AVRT. So what is AV-NRT? AV-NRT is basically your slow-fast pathway in the AV node. In this, baseline ECG would be normal in these cases, but when the tachycardia, the P waves will be buried inside the QRS, so we can get a pseudo R wave in V1 and pseudo S wave in inferior leads. If we see this ECG, there is subtle R wave or there is deflection post QRS in this case, suggestive of AV-NRT. What about AVRT? AVRTs are basically the bypass tracts, or this is basically accessory pathways. We connect atria to the ventricle, and they have a rate about 200-250. If it is conducting through it, it will be a WPW syndrome, and if it is not conducted, so baseline ECG would be normal, but during tachycardia, we will get a narrow QRS tachycardia with P wave in the STT segment. In this, the P wave is little later, more than 90 milliseconds in these cases, and we get P wave falls at the STT segment, so there will be PR segment will be depressed. So we get a AV reentrant tachycardia in these cases. What about the RP interval if it is very long involved? So in these cases, we should suspect atrial tachycardias. This is usually seen in your 5 to 15% of SVTs and more in pediatric population and post-cardiac surgeries. And these patients usually have a incessant type of tachycardias, and they cause tachycardiomyopathy. So if you see this ECG, this is a narrow QRS tachycardia, but if you see the P wave, it's clearly outside the QRS, and it is the, if you see the RP interval, it is a long RP interval. After looking at this, sometimes again there is sometimes confusion that we are not able to differentiate between the DDs of it. So this comes the response to AV block, which I tell AV dependent tachycardias, AV node dependent. So this becomes helpful in the establishing the diagnosis. So if we suppose do the AV nodal block and we can see the P waves clearly, then it helps in the DD. So how can we do that? Either by a carotid sinus massage or a Valsalva, or you can give a adenosine. So if we suppose do a carotid sinus massage and the AV node conduction decreases, and we are able to clearly see P waves in these cases, the P waves are more than QRS, it's suggestive of you that it is foci is in the atria, in the form of the atrial tachycardia or in the form of the atrial flutter. And if you are not able to see it and suddenly it stops, it's more favoring into your reentrant type of tachycardias, AV-NRT or AVRT. What about the adenosine? So adenosine is the, when we give in these to differentiate between these two, or sometimes the therapy also. So if we sometimes have no response, that means either the inadequate dose has gone or it is not SVT, it is maybe a fascicular or septal VT type thing. If it is a gradual termination, it may be seen in your sinus tachycardias and sometimes automatic focal atrial tachycardia because it's not depending on the re-entry tract. And if it is a sudden termination, that is a AV nodal dependent tachycardia, either AV-NRT or AVRT would be suspected. And this, if we give adenosine, the tachycardia persists, but the QRS is less than the P wave, which morphology we are seeing. That means that we are dealing with your atrial tachycardia or the atrial flutter in these cases. What about these patients in management part? These patients are relatively stable as compared to wide complex tachycardia. So they can be managed first with your except cardioversion shock. So if they are hemodynamic collapse, DC shock is the preferred treatment. But if the patient is hemodynamically stable, we can ask for the patient to do vagal maneuvers in the form of Valsalva or carotid sinus massage, or we can, these patients have a IV adenosine is the drug of choice of class 1 indication, 6 to 12 milligram in these cases, and if it is ineffective, then you have to give IV verapamil or diltiazem, or IV beta blocker can be given in these cases. And if it's still ineffective, you have to give a synchronized cardioversion. So if we just, what we have just described in last 8 minutes, we can have few examples and apply in these things. So if we see this ECG, it is a narrow QRS tachycardia. Is it regular or irregular? It's a regular rhythm. Are we able to see the clear-cut P wave visible? They are not very clear, but they are emerged inside the QRS. So if you see that these are the P waves, in the V1 there is a slight deflection post QRS, and in inferior lead there is slight deflection in the S wave. So these point to the retrograde P waves, which P waves are very smaller in short interval of the RP interval. So this is more of your AV-NRT type of a thing in these cases. What about this ECG? If we see this again, it is a narrow QRS tachycardia. It's regular. P waves are visible. Atrial and ventricular rate is same. And if you see the RP interval is more than PR interval. So this is basically a narrow, can be long RP, atrial tachycardia, or it can be atypical AV-NRT or a PJRT. So in summing my presentation, patient comes to you, narrow QRS tachycardia, look for regularity. If it is irregular, 3 DDs to be ruled out, fibrillation, tachycardia, flutter or MAT. P waves are visible. If the atrial rate is greater than the ventricular rate, atrial foci should be suspected. If the P waves are not reversible, look for the RP interval. RP interval is small, then it's more right. If RP interval less than 90 milliseconds, it's AV-NRT. If it is more than 90, it is AV-RT. And if RP interval is more than PR interval, it's atrial tachycardia, PJRT, or atypical AV-NRT. So this sums with my slide. Thank you.
Thank you very much, Dr. Roopali. Please have your seat. We'll come back to you for the discussions at the end. Ladies and gentlemen, with the permission of the chair, may I invite Dr. Daljit, please.